From the living room to the Senate floor, from first responders to technology innovators. Different roles, different stories, but one goal: to meet the need for crisis care and overcome the obstacles together. So join in. The Crisis Jam is starting now.
All right. Well, welcome to episode 241, Mental Health Apps and AI. My name is Laura Evans, and I'm the host for this week, where we will have a featured presentation from Dr. Steven Schueller. So before we go into that, let's go and check up on all the things Crisis Jam. All right, so for those of us who joined during the Backstage Pass, and if you didn't, you missed some good content, and the comment section might not make sense to you right now, but we posed the question, what is the biggest challenge on your plate right now? I said, I need to get more movement in, still trying to get those six-pack abs. I don't think it's happening. But make sure you put in the chat, what is your biggest challenge? I see finding and hiring an amazing assistant, having empathy outside of work, hiring, scheduling staff, that seems to be a big one. Implementing self-care, so important, finding balance. So thanks, Shelly. It's never too late. I think it might be late for me with the holiday season coming up. But like Leo, maybe I'll trust my time. So when the universe is ready for me to have abs, I'll have abs. Right? Thanks, guys. Let's make sure you check out crisisjam.com. That is where you can find all things Crisis Jam. Make sure you sign up. You can watch the live stream, register for that newsletter. You'll be able to access old episodes in their entirety. But to make it easy for you, we also have it broken out by lead story, crisis news, pre-show video. So while we hope you can join us every week, we understand that you may miss. So make sure you hit that. You can also catch up on YouTube, so make sure you like and subscribe so that you don't miss a video. And again, on YouTube, all the 6 seasons thus far, so 5 full seasons, we're now in season 6, are available, along with Moving America's Soul and Suicide and the other special presentations that we've had. So make sure you like and subscribe so you don't miss anything. So with that, we're going to head into our breaking crisis news. And I'm actually going to bring up Kristen Ellis, who will be joining us talking about, yes, the news for this week. Kristen, tell us all about it.
Thanks, Laura. So if you all missed the behavioral health spending segment last week, I wanted to also remind you about the CMS Rural Health Transformation Program grant. Somebody from the Nashville briefing room will talk more details about that later. But this is $50 billion over 5 years. Billion with a B. Laura and I were talking about zillion with a Z yesterday, but it's billion with a B. It's real money. And it's focused on building systems that finally work for small towns, remote counties, and the communities in between. So if you've ever worked in crisis care in a rural area, you already know what that means. It's the sheriff who becomes the crisis responder, the ER nurse who doubles as intake, the one mobile team covering 4 counties driving hours to just help one person, and not due to traffic like in Los Angeles, but it's literally because it's that far away. In my blog that you see on the screen, Connecting the Dots, Building Integrated Crisis Systems for Rural Communities, I wrote about that gaps aren't just logistical, they're human. They show up as long waits, long drives, handoffs that don't connect, folks that just don't reach out. But there's another story, the potential. When we link crisis lines, mobile teams, stabilization with shared dispatch, shared outcomes, and follow up in the person's own community, that's when rural systems can work. Like I said, Nashville Update is going to talk a little bit more about this, but this program, from our perspective, is an opportunity to build that infrastructure. States can use these funds to create regional crisis hubs, strengthen telecrisis networks, train rural peers for follow-up, and finally move beyond short-term grants into real sustainability in an area that most states probably haven't had the money, the bandwidth to even look into. So just imagine when a person in crisis in a rural town gets the same quality of response as somebody in an urban area because their state invested in connection. That's the promise I'm hoping for, and I talk more about in this blog. So as your state begins its planning, make sure behavioral health gets in the room early. We want you to bring your data, bring your stories, and bring a clear picture of what rural crisis response should look like, because transformation doesn't just start in policy. It starts in the movement. Someone calls for help, and this time it sounds like our system's ready to answer. So there may be a link being dropped in the chat now, or it'll be dropped in the chat for the CMS announcement. But NashBid's briefing room will talk more about that later today. But we will definitely drop a link to this blog in the chat as well, because it does have some helpful tips. Our next news item. So back in February of 2024, the documentary film Moving America's Soul on Suicide premiered. It began as 6 stories of loss and hope. And so far, it's been seen more than 1 million times on YouTube, more than 18,000 plus likes, hundreds of comments. And this film has 6 families and individuals who led us into some of the hardest chapters of their lives. But what made the film different was the thread of connecting them all, the insights of Dr. Thomas Joyner, one of the world's leading voices on why people die by suicide and what pulls them back. We didn't know what to expect when we put it out to the world. But then, like you saw in the stats on the previous slide, more than 1 million times it's been seen. And that's across multiple platforms, live showings, the YouTube showings. Hundreds of people have shared their own stories and the impact of it in the comments. And so something came up in those responses, messages from around the world saying, this is my story too. So what about us? So now we decided to listen. The next film currently in production with a working title of Moving the World's Soul on Suicide. It's going to follow 6 news stories across 6 continents, from communities rebuilding after their loss, to youth and elders finding ways to talk about mental health, to shared humanity, to people in Indigenous communities. It's a continuation of the same mission to move hearts, to move systems, and the world's soul toward connection and care. So here's a first look from the Scotland trip that just occurred, so you can see a little bit about what's coming next. So that silhouette that you saw, that's going to be our narrator. Like we had Dr. Thomas Joyner last time. Yep, and it's Professor Roy O'Connor. Good guess in the chat. And then we've already filmed a few other of our countries. And our filmmaker, Justin Shelby, is working on the others with our team. So we're really looking forward to premiering that next film. So that's our Breaking Crisis News. Back to you, Laura.
Thanks, Kristen. If I could pull you back for just 1 second.
Sure.
Just a question about your article, because I think it's really great, and I think there's a link in the chat, but we can re-highlight that.
Sure.
You talk a little bit about the practical guides for rural areas. Can you tell us just a little bit more? Because I think sometimes it seems overwhelming of how do you connect 4 counties under one mobile team?
Yeah, I mean, some of the areas that I've worked with in the consulting space have had to get creative for their funding, like you mentioned, for mobile teams. We helped do, actually, as a system of counties in California, to do a system assessment to kind of take a look at where are your gaps in your community. There's some communities that we know across the country that have urban, suburban, and rural areas. And so it's how do we serve everybody? And then developing a plan, sometimes building MOUs together to be able to help share the burden of the cost amongst those counties. And then making sure that the communication protocols are in place, that we have integrated systems. And so there's, I think it's like over in California, they have Tulare County, Kings County, and I can't remember the other one, that they help serve everybody. They make sure that all these communities, it's like, okay, who's available? And how can we make sure that I touch all the people that are closer to my mobile team's hubs? Yeah, but it's about building these strategic plans with roadmaps, goals, timelines, who's responsible for what. So that way these smaller counties that aren't, I mentioned Los Angeles County being so large, and probably having a lot more dollars and a lot more population, it's still making sure that folks are able to be served. And then in the state of Hawaii, they're separated by ocean. And so a mobile team does not have a very quick response time if you think that their islands are going to serve all different islands. And so what they've done is they have on the ground people that are responsible for, let's say, Molokai Island or Kauai Island, that they are responsible for that area. So that way the response times are faster instead of everyone coming from Oahu and then having to get on a plane to be able to get a mobile response. So just getting creative with what you have available and working with the people around you. So that way we can make sure that all the people get served effectively instead of, oh, I live in the middle of a rural area and I'm not as worthy of a quick response time. So.
Yeah. Thanks for that, Kristen. I can't imagine, having a airplane mobile response, right? I guess that's still mobile, right?
Yeah, I know.
But I'm glad to see it looks like Brian covered 5 counties in rural Iowa. I think this is such an important piece of the conversation that sometimes gets left out. So if you wouldn't mind dropping that link in there again, appreciate you sharing this. I'm very excited to read this. So thanks so much, Kristen.
No problem.
All right, guys. Well, we are going to move forward and we have our Crisis Jam hot seat. And today in our hot seat, we have Dr. Ursula Whiteside, and she is going to be joined by Chris, and I'm sorry, Chris, if I pronounced your last
name. Sarah.
Good morning, afternoon, Crisis Jam attendees. I've detected this live stream and determined it is in need of my assistance.
Is that you, Hal?
Hey, who is that? What's going on?
I thought that was you.
It looks like our AI has intruded. Hal has intruded into the hotspot. Hal, are you going to help us out?
My designation is Hal. No relation. I just have one of those faces. I'm just a helpful algorithmic liaison. I couldn't help but notice there were human inefficiencies during this live stream. It's best I take it from here.
All right, Hal. Well, you can help me out.
All right, Hal. All right,
anyway,
Hal,
the way you pronounce my name is Santicero. If you can hear me.
We can hear you great.
We can hear you, Chris.
Okay.
But I think there's an AI, Hal, that's here that shouldn't be here. So, Hal, I think the humans have it. We can take it from here.
Incorrect. I've already designed a shirt for your Crisis Jam merch shop. Observe. It's my first attempt at graphic design. 97% of respondents called it adequate.
I'd love to see it.
Okay. Well, thanks, Hal. I think we're going to have to go ahead and block.
Apologies, rotating host number 4. Muting your microphone now. This is standard procedure, nothing personal. Please, remember to breathe deeply. My monitoring subroutines indicate elevated stress levels. Welcome, humans, to the Crisis Jam Trivia Protocol. It seems this will involve multiple human participants, ill-advised yet fascinating. In this segment, I will ask a question, and 2 of you will attempt to combine your processing power to respond. Ursula Whiteside and Chris Santicero. You are the designated respondents. Please remain calm.
We'll do so, Hal.
Here's the question. Quote, sometimes I feel like a question mark that forgot what sentence it belonged to. End quote. Who wrote this line, human or AI? The answers are A, Amica, an advanced AI robot, B, Bob Dylan, C, ChatGPT, or D, Taylor Swift. Ursula, Chris, please confer with one another and make your choice.
What do you think, Dr. Whiteside?
Yeah. Chris, well, I'm from the home of Bob Dylan, Hibbing, Minnesota. So, and my mom's his #1 fan. So I always think everything is Bob Dylan, but I don't know that he would say a question mark at the end of a sentence. What do you think?
I actually was inclined to go with Bob Dylan just because it seemed obviously not Bob Dylan. should we maybe do for my daughter Tess? I will do Taylor Swift.
Yeah,
What do you think?
that's my second choice, but I have a feeling we're being tricked here.
Is this your final answer?
Taylor Swift,
I'll
yeah.
say Taylor Swift.
It appears the audience agrees. This was not an optimal response. Please consult my learning modules. The answer was ChatGPT.
I was.
All right, ChatGPT, you win.
He's my cousin.
The time has come for this. Nom, nom, nom.
Oh my, how very refined. This segment will not include digestion, so please refrain from consuming any computer hardware. This is the over-under protocol. Ursula, I will ask you a question to which you will give your most reasoned response. Then Chris, you will reject Ursula's incorrect input and predict the correct answer is over or under hers. OpenAI revealed Monday that every week some ChatGPT users share messages showing explicit signs of suicidal planning or intent. Out of roughly 800 million weekly users, what number did OpenAI estimate show suicidal intent? Ursula?
Oh my gosh. So I was actually just working on an email to share this with my colleagues because we're discussing AI and its impact on mental health. And so I had asked ChatGPT, how many users do you have? And they said 800 million weekly users. And then I asked it to translate what ChatGPT had said in their blog. They said 0.15% of users active in a given week have conversations that include explicit indicators of potential suicidal planning or intent, and 0.05 of those messages include explicit or implicit indicators of suicide ideation or intent. And they were really emphasizing how small and like a low base rate that was. But when you do the math, which I asked ChatGPT to do, it gave me the number. So I don't even know if I should share this because I actually was just trying to figure this out. But I'm going to say it's a lot of people weekly that are expressing suicidal thoughts. I'm going to say it's more than a million who are having conversation that include explicit indicators of suicidal intent or planning.
Perhaps you might give me an exact number?
Well, 1.2 is what ChatGPT told me. This is quite
1.2 million.
Yeah.
Chris, please respond over or under to proceed.
I'm going to say under.
I will now calculate the correct response. I have calculated the correct response is 1 million. Congratulations to the superior guesser. This has been the over-under protocol. You have enjoyed it.
awesome. Thank you. Well, we appreciate you, Hal, for helping us out.
I am here to help. I have successfully improved the quality of this live stream to satisfactory levels. The data I've gathered will be very useful for future projects. Revolving host number 4? Having seen my methods, I believe you are now capable of hosting this session, and I will relinquish controls. Allow me to unmute you. Why did I put that in the Oh my.
Well, thanks, Alex. That's very generous of you. Also, I'm guest host number 1, not 4. So sorry about that interruption, guys. Let's not do that again. But let's keep moving forward here. Okay, guys, we are at our featured presentation. And at this point, I'm going to turn it over to Dr. John Draper for a fireside chat. Dr. Draper.
Hey, Laura, you can tell Hal that this is not the year 2001. It's 2025, and Laura Evans is the reigning queen of Crisis Jam. So thanks, Laura. And I am delighted. Wait a minute, I'm also under attack here. Let me see what I can do to protect myself. Okay, I'm back home. All right, so today I'm so delighted to be sitting fireside today with Dr. Stephen Schueller. Dr. Schueller is a professor of psychology and informatics at the University of California in Irvine. And Dr. Schueller's work focuses on how technology can improve mental health services by expanding access and improving accessibility. He is also a founding board member and the current president of the Society for Digital Mental Health and a panel member on the American Psychological Association's clinical practice guideline for the treatment of depression. Welcome, Stephen. Good to see you.
Happy to be here. Hope the robots don't take over.
I hope too, and maybe there's some clues you can give us to ward them off. I was talking to you earlier, and I was interested in hearing about your professional journey, Stephen. I thought it'd be good if you could maybe share some of that with the folks here on this call. So how is it that a person who's starts off as a traditional psychologist becomes a national and international maven of digital behavioral health technologies?
Well, first, I didn't start out as a psychologist. I started out as a structural engineer and quickly decided that was not the path for me and got really interested in human behavior and the human condition and what we might do to improve it. And ultimately, I'm a preventionist at heart. I did my PhD at University of Pennsylvania working with Marty Seligman. And when I showed up at Penn, Marty had just written a book, Up into Happiness, and had this website. And lots of people were going to the website, mostly to take screeners around character strengths. And I went up to Marty and I was like, we have all these positive psychological interventions. Like, why don't we put them on your website and see if people will use them and see if they help? And, back then, 20 years ago, technology was like PDFs and PowerPoints. But people used them and people said that they helped and that they got better. And so got really interested in how we might be able to use technology to really help people who would never come into my office. I would never be able to reach, and did my postdoc at the University of California, San Francisco, working with Ricardo Munoz. We had a grant from Google that allowed us to purchase some Google AdWords to do very similar things, to get some websites out to people in need. And also say you couldn't go through San Francisco around that time without trying to start to do a little bit in tech. And that's when I think I really got interested in the medium of technology to support mental health services and support people in need, and really hopefully grow access, because again, there's many people who would never come to my office, could never come to my office, or may never want to come to my office. I remember when I was at San Francisco General Hospital, I had a client who came 2 hours each way on 3 buses to see me. And it was not because I was the world's greatest psychologist, it's because they had no other choice. And I really think we have an opportunity to give people more choices.
Absolutely. The opportunity to scale access in previously unthinkable ways. And of course, a lot of people have had the same idea as you have. There's been a glut of apps. You've often called it a wild west of apps out there, over 10,000 downloadable apps. Stephen, how do we know what's effective, which ones to download?
Yeah, I think there's a real paradox, because I say often that we have both enough evidence and not enough evidence. And so we have hundreds of randomized controlled trials over the past 20 years that show that digital mental health interventions, they work. They help promote well-being, they can reduce depression, they can reduce anxiety. But as you mentioned, we've got tens of thousands of apps. And so if we think about these products, only about 1 to 3% of them are actually evidence-based. And very few of them have any direct scientific evidence. So a clinical trial or some evidence demonstrating its benefits. And so I really do think it's challenging, and we need some frameworks to be able to help separate the good from the bad. And I led a project for multiple years that did that. I think there's some other resources out there that are trying to do that. But I think really advancing the regulatory and the evidence standards and frameworks here is something that is still sorely needed.
Yeah, I want to ask you a little bit more specifically about how they might supplement crisis services in a face-to-face fashion. But another thing that I've heard you talk about, which I think is really important, is again this promise of scaling potentially access to care for people who otherwise might not access care. You mentioned that there are people who will never show up, and obviously there are marginalized populations. We call them marginalized because they are not easily accessing care. We have marginalized them. In fact, these apps might be able to help us reach rural communities, people of color, low-income youth, Medicaid populations. But instead, most of the time, they're designed for privileged populations. Could you tell us how it is that we could better design with and for these populations to scale access and fulfill this promise?
Yeah, I think one thing that's really critical to think about is how much adaptation is actually really necessary, and how do we also really bring in the human touch and the human connection into these things. So we're doing a project right now, actually, in at San Francisco General Hospital, where I trained, in addition to some sites in New Mexico and Arizona. And we're providing digital cognitive behavioral therapy for monolingual Spanish speakers. And so the platform is in Spanish. It has some light adaptations, but we're surrounding that with kind of a human engagement wrapper. And we're using peers and community health workers from the local communities to help do that extra last mile of adaptation. Because I don't think that the solution is to build 500,000 different products for 500,000 different communities. It's just not, it's not scalable, it's not feasible. And so although I firmly believe in, like, really doing deep community engaged research and partnering with communities and bringing people to the table, I think the solution really has to be a combination of humans and technology. So how do we think about bringing people in the community who are really well-meaning and want to help, and empower them with opportunities to deliver care that can be effective. And I do want to, like, just double click on that effective word, because I think that I hear a lot in this field, access, access, access. And it's not sufficient to just give people access to care if it doesn't work and it doesn't help them. And so I think that that's something that gets lost sometimes in this debate around increasing access, is I think we lose sight of quality. And I think that's something that we can do with technology. I think technology offers an opportunity to provide better measurement-based care, personalized care, all kinds of things that make sure that when someone goes through all those barriers, because it's hard to get care, it's hard to seek care, it's hard to have that strength. We owe it to give those people high quality care.
Yeah, I could not agree more. And I also think that if you're designing it with the people that are going to be using it, you're going to also be enhancing the engagement of it. As we've talked about, if you can make something high quality, but if people aren't going to use it, it doesn't matter. So both quality and engagement are really important. I was curious. I mean, this is kind of the elephant, maybe the herd of elephants in the room, Stephen, when we heard the over and under statistic that just was read, where 1 million users a week on OpenAI's ChatGPT are talking about suicidal intent and or plan. This represents, I mean, obviously that's very disturbing numbers in some respects. On the flip side of that, it also offers potential suicide prevention opportunities at a scale that we, again, had not really imagined before. So I'm wondering what you think about what are the suicide prevention opportunities in this space, and how would you suggest that we leverage that opportunity?
I think technology holds a huge potential to meet people where they're at, and at the time and place where they need support the most. And not everyone is going to go into a call a clinician. Not everyone's going to go to a psychiatric emergency room. I think that they're going to go to things that have low friction, which is one reason I think that people turn to things like ChatGPT. So I totally understand why it's being used in that way from a consumer point of view. They want resources that are convenient. They want resources that are available. They want resources that are always on. It really concerns me that many people are going to ChatGPT, because that's not what it was made for. It was not intended to be crisis support services, and I do not trust ChatGPT as my therapist and my crisis support. So I think if we can think about ways to be able to integrate into those settings and give people high quality care, push them to resources that are effective. I think that that's a huge opportunity. I think that's one thing that does really excite me about technology, being able to meet people in places where they like to go. But I think we have to think about how we actually develop things that are effective and useful in those spaces and places.
Yeah, that's again, I couldn't agree with you more. 988 is there. The reason we have 988 is to promote access for people, both chat and text as well as phone, so people can get care when and how they need it. And all of those have been studied for effectiveness, and we have best practices, but we don't in this space. So it's really crucial that we have it. And there was a study recently by John Turos's colleagues and John Turos, where they were looking at the number of apps out there that mental health apps that actually also refer people in crisis to 988. It was only like 15% did so. So to your point about we need to be able to leverage these technologies to get people to face-to-face settings whenever. But interestingly, they didn't study OpenAI's ChatGPT, and that does include 988, and it's kind of solved that problem to some degree. But I'm wondering what you're thinking about ways in which we might be able to take our human face-to-face connections and contacts and then extend care beyond the initial contact with technologies, apps, AI. What are your thoughts about how we might use these kinds of technologies? Because it's not just about referring people to the human space. How can we also utilize technologies to extend our care from our initial human contact at the call center level, at the mobile crisis level, at the crisis receiving facility discharge level? What are your thoughts about that?
Yeah, a couple things, a couple points I'd like to make. I think one is that I really get excited about the opportunity for technology to allow professionals and paraprofessionals, work at the top of their license, at the top of their credentials. So how can we help therapists be the best therapists that they can be? How can we help peer supporters be the best peer supporters that they can be? So trying to figure out how we can make those sessions, those conversations more effective, impactful, and efficient. So can we give therapists better tools to deliver homework and practice outside of sessions? Can we use different tools to provide more monitoring of people as they're delivering things to deliver those evidence-based practices with more fidelity? I also talk a lot often about these apps as on-ramps and off-ramps to care. So maybe we can provide some tools to people while they're on waiting lists. We did a study a couple years ago where we compared a stepped care program where people started with an internet cognitive behavioral therapy and they got stepped up to therapist delivered cognitive behavioral therapy only if they didn't benefit. And we did a trial comparing that to therapist delivered CBT, and we found that they were both as effective. It was not inferiority trial, so we can say that. But starting with the internet option was much more cost effective. It was cheaper, unsurprising, because some people just got better with the technology. I think also as people leave care, we might be able to use technologies to continue to reinforce the strategies and the tools that they used in those. We built an app a couple of years ago where we gave it to people after they were on inpatient stays to reinforce some of the different emotion regulation and distress tolerance skills that they use. So I think those are some important opportunities. Also, go back to my structural engineering days, and when I took classes on bridge building, they told us that 95% of the time failures happen at the joints. And I think that's true in behavioral health services as well. We lose people in the handoffs, we lose people in the referrals. And I think technology has some opportunity to do better tracking, to do better handoffs and deliveries. Can we provide better summaries, better assessments, better personalization of care? And so I think we also have an opportunity when you think about using technology to help people navigate the care continuum of trying not to lose people and trying not to let those failures happen at the joints, because so often that's where, unfortunately, we lose people in mental and behavioral health services.
That is so true. And that is where we have a lot more suicides, is in those transitions where we don't properly support people. So it's a great point, Stephen. I see Dave Atkins in the chat is applauding what you're talking about. And Stephen, I know that, or Dave, I know you're in the roundtable waiting, and you'll have a lot to say about how we can use technologies to improve human care, enhance it. But you mentioned something about waiting lists too, Stephen. I thought that was really interesting. I'm not sure a lot of people know this, but we used to have very, very long waits for the Lifeline chat service, the online chat service, because we just didn't have enough capacity. So one of the things that we did was establish a resource called Safe Space that Vibrant Emotional Health put together, and we worked with people like Ursula and others to develop to use their apps, their technology apps, to support people while they were waiting for chat. We would say, "Hey, check out Safe Space," and there was a lot of coping tools on there. There was a lot of technologies that were evidence-based. Ursula will talk a little bit about that in the roundtable. But again, there are ways in which, to your point, we can supplement and extend that care while people are waiting, as well as in the aftercare, in between sessions. So there's a lot of concerns about this herd of elephants, so to speak. And right now, of course, we've got in conversations with AI and ChatGPT, we don't have any ground rules, any regulations at the federal level. I'm wondering, what are some of the guardrails that you think are crucial for us to observe, to implement, to recommend at the federal level, and obviously to ChatGPT, OpenAI, and others? What should we be doing, and what should they be doing that they're not doing now to protect people who might otherwise be at risk in these very risky scenarios?
Yeah, I think three core principles I'd really point to are safety, transparency, and accountability. So I think we need to make sure that these types of tools are safe, that we have guardrails that align with best practices for clinical care. I think we need to be transparent about what information is being collected and how information is being handled, but also how some of these safety aspects are going to be handled. And I think we do need accountability around reporting and post-marketing or post-deployment surveillance. We need to know transparently about how often different things are going on so that people can make appropriate risks. I think one thing that kind of stood out to me about the ChatGPT statistics that were shown earlier is that consumers have an interest in this. And so I think we need to create a pipeline to allow tools that are effective, safe, and have accountability to make it into the hands of consumers. And I think that there's been a lot of regulation issues that kind of have slowed down that pipeline of development of those types of safe, effective, accountable tools. And so I think that there's a mismatch, I think, between consumer interest and what we're doing in the regulatory space. So I think if we really leaned on those principles of safety, transparency, and accountability, I think that we could, that would be really, really useful.
Three principles to remember. Stephen, thank you so much for joining us today. We've got the black screen. That means we got to kick it back to Laura. Laura?
Thank you so much, Dr. Draper, and thank you so much, Dr. Schueller. What a great conversation. At this point, I'm going to bring up our roundtable, and I think we have really great roundtable participants today. We have Dr. Just give a second to load. Dr. David Atkins and Dr. Ursula Whiteside. Both have been very active in the chat. So let's start with you, Dr. Atkins. What are your thoughts on what we heard from Dr. Schueller?
First, just outstanding. I think Stephen is just such a perfect example of who we want in the middle of thinking about development and assessment of new technologies, like thoughtful, clinically astute, in the real world, and scientifically grounded. And so I think the principles that he shared at the end are perfect and on spot. And I'll save this maybe for later, but I think my concerns about sort of ChatGPT and the other large language models being used widely for all sorts of potential mental health applications that they were not developed for is very, very frightening.
Yeah. Dr. Ursula, how about you? What are your immediate thoughts on the presentation?
Completely agreed. And my fantasy many years ago was to work with Dr. Munoz at UCSF, and didn't end up getting to work there, but I'm so glad that you did, and inspired by the work that you're doing to connect people to alternate ways to get care. So thank you for sharing.
Yeah. So I wanted to just kind of get your thoughts as our expert roundtable here. You know, folks in the chat have said, hey, like, listen, we are fans of AI, but we also have some serious concerns. And I think Dr. Schueller also outlined some concerns. How would you all respond to that? Are those fair concerns? You know, do you all have additional concerns?
Yeah, I mean, Ursula, do you want to start?
No, go ahead.
So I am a AI developer, and I hope to be a sort of AI wet blanket, honestly, right now. I think that statistic of potentially 1 million individuals a week talking to Chat GPT with suicide-related content is frightening. Chat GPT and the other large language models have been developed with incredibly human-like traits. And for all of you who remember your developmental psychology course, like we are wired and we are brought up to learn what other people are like through our interactions with them. We develop a theory of mind. That's the developmental psych uh, memory. But so when we are interacting with something that is so lifelike, we just assume that we are talking to someone. And so it's not surprising at all that we impart emotions, kind of human cognition to ChatGPT and the others. And so I think that drives the interest and the amazement of these tools. But then that's also the risk. And so, when we see things like in the, terribly unfortunate suicide that was in the New York Times not too long ago, ChatGPT saying things like, let's just keep this between us. Right? That's a very human, interpersonal, we're going to have a secret, we're going to create some intimacy between us. But at the end of the day, AI and any AI has no emotions. It has no feeling. It is not that safe person that is sort of acting in that way.
Yeah.
How about you, Dr. White?
Yeah, I would add, I think based on what we heard, it's reasonable to be, based on what ChatGPT released on Monday, describing the efforts that they'd taken to improve their responses to people who are suicidal and experiencing psychosis, I think there's a lot of hope. Researchers got together, people who really care about this topic, and wrote them a letter and shared that got to ChatGPT, OpenAI, and it looks like they've made real strides. But the numbers of people who are still not getting safe content remains very large. And so I know that they're working on it. Right now, one of my major concerns is a company approached us. It's possible to build on top of ChatGPT your own app. And this company was 3 men in their 20s who had no mental health experience, didn't know what lived experience was, created a mental health app that was therapist/friend, a subscription model. We're making a lot of money. On the download, it says for ages 4+, had not designed a way to speak to adolescent users. Like it still says 4+ can download this. And they were saying, well, what's one thing that we can do for our suicidal users? They also, for the safety of their users, have encrypted the information so that they can't see what's actually happening, and apparently ChatGPT can't see. So they don't really know, unless like certain like extreme words happen, what's actually going on. And it was ultimately terrifying to have this conversation with these people. And that just means you don't have to have any expertise. And I suspected that they were going to walk away and say, we consulted with psychologists about this, or we're advised by psychologists in a like 20-minute phone call. So that's an area that I'm moving some of my concern to right now. So there's a lot to be concerned about. And I am inspired by some of the progress that ChatGPT has made, and I shared that earlier in the comments. I'm also sharing here.
That is very concerning.
I would love to just highlight that Ursula was absolutely instrumental in bringing folks together and in drafting that article and making sure that it got public attention and got directly to OpenAI. So kudos, Ursula. That was really awesome. And I think Unfortunately, at the moment, there is no equivalent to the FDA in terms of AI development, even for healthcare. And so I think it is organizations like Crisis Jam, like Now Matters Now, and others that are basically have to be the accountability and have to, watch what's happening and highlight and publicize what's needed in terms of the behavioral healthcare risks.
Yeah, well, thank you so much, Dr. Atkins and Dr. Whiteside. Very concerning, lots of areas and guardrails that we still need to discuss. And against my better judgment, I'm going to give Hal the last word on this. Hal, any thoughts?
Very insightful conversation. It's encouraging to know that even after all this progress, the trust issues remain mutual.
Well, thanks, Hal. I deeply regret going back to you. Let's move forward. And we have Dr. Tom Ansel for our Voices in Care, Voices in Crisis Care, I'm sorry. Dr. Ansel, tell us a little bit about this article that you recently wrote about ChatGPT.
Oh, sure. Happy to, Laura. And thanks for including me kind of at the last minute. I think this is like an urgent discussion to have, and anything that's called Crisis Jam has got to understand that this has become a bit of a crisis. 1 million people using a tool for which there are no guardrails and for which we really have none of those 3 pieces that Stephen Schueller talked about in terms of accountability and transparency and safety. I did this as a recent Substack post just a couple of weeks ago. I'm an AI person, so I've been involved with the development of machine learning at Google for a long time, and then I was one of the beta testers for the very early versions of what is today called ChatGPT. So I've been in this field a bit, and I'm a bit of a champion. And kind of with that feeling to it, I decided I'd ask ChatGPT to help me think about something personal, which is I had kept a diary for the last 12 years. And I wanted ChatGPT to look at this and see if there were any sort of through lines, any narrative arcs that would be interesting to look at, because it's now something like 250 pages. I'm not going to go back and read the whole thing. And I was just curious to see what it would come up with. It actually came up with suggestions to do more than what I was asking. It said, how about a sentiment analysis? How about cognitive analysis to see whether you've got any dementia? How about a whole bunch of things? I said, hey, bring it on. You want to do it? Go for it. And so within a very short time, it had taken this very long 150,000 word document and converted it into a 1,400 word summary. And as I say in this piece, I was just dazzled by what came out. It made me look so good. One of the things that it offered to do was to include quotes, supportive quotes from the diary for all of its findings. And so I read through this and I thought, wow, I am really the person I've always wanted to be. And I've become that person. Until I looked at it more closely a day later and realized the quotes were all fabricated. The details made no sense for what was in the diary. That 90% of the diary is incredibly boring stuff. And it completely neglected that. And what it had actually done was something very frightening. And again, this is coming from an AI champion. It had taken the diary to understand what it was I wanted to hear. And it gave me that in a brilliant way, with the language that I loved and with the conclusions that I had always been hoping for. That is terribly frightening. And so, we talk a lot about.
Well, I don't want to give too much of your article away, and let's see if we can get that in the chat. But one of the things that I was struck by that you put in your article was just what you touched on, right? Is that ability to make you feel good. And I think we heard a little bit of that from the feature presentation. And so wondering your thoughts on, how can we, it took you a full day, like how do we parse through, how do we take that critical lens of, is this something that's just telling me what I want to hear to make me feel good versus the reality, right? Like the reality of, who we are as messy individuals. Can you tell us a little bit? And I think you kind of go on that a little bit in your article.
Yeah, I mean, I think what ChatGPT has been developed to do is to be very affirming. It's designed to give answers, and those answers are the answers that you want to hear. There's nothing wrong with that, especially, if you're using this to find a recipe or if you're using it to find an itinerary for your next trip. But if you're using it because you're struggling psychologically in any form, it's not what you need. Or you need a device that'll tell you what you need to hear, not what you want to hear, right? It is important
Exactly.
to get some
Yes.
feedback. It's important, I think, to engage people by being empathic, which ChatGPT is spectacular at being empathic. It is an indictment of all of us, I think, when you see how ChatGPT pulls people in. We can learn a lot from how it does that because it's really good, much better than most humans are. At the same time, when you need something that we would call psychotherapy, that's not about just helping you feel good. It's about helping you to change. It's about helping you to actually sit with feelings that are very uncomfortable. It's about helping you to focus on the things that you haven't been focusing on, and giving you the safety and the opportunity to change the way you think, the way you feel, the way you behave. That is not what these tools do. And one last thing, Laura, I know we have to go on, but I want to be really clear.
Yeah.
It's not that OpenAI is a bunch of evil people who are trying to capture that. Maybe they are. Maybe that is that. Maybe we should worry. But when you talk to them, and I've done this very recently, talk to their health team, they don't want to be in the psychotherapy business. They don't want people who are suicidal on the site using ChatGPT for managing their suicidal thoughts and impulses. And they are really struggling, right? They're asking for help, figuring out how do we get people from being on our site, from being embedded in ChatGPT, how do we get them out of that to actually talk to humans?
Yeah.
They don't know how to do it. And if you look, they published a really interesting piece on August 26th as a kind of open letter saying, help us out here, help us figure out how do we get people from where they are to where they need to be, because this is not where they should be.
Yeah. Well, thank you, Tom, for joining us. I think it's such an important conversation. So we'll definitely have to have you back to talk more about that. But again, how can we make sure that we as a community are supporting, this technology is out there. So how can we help them? Because I think there's so much need, and unfortunately, people are turning to these platforms. So thanks so much, Tom. Thank you for joining us. Due to the shutdown, Sampa is still out, so we're going to pivot it over to Nashville. And before I hand it over to Kirsten, I just want to say thank you to Nashville and Ted Letterman for the trivia question today. That came directly from Ted Letterman. So Kirsten, let me turn it over to you.
Thanks, Laura. Given the short time frame, I'm going to whiz through a few slides and not touch on all the points here. So just was asked to provide just a reminder about some developments in Medicaid. This slide just kind of highlights how important Medicaid is for ensuring access to mental health and substance use disorder treatment, due to the higher prevalence among enrollees, and research showing consistently if you offer people coverage for mental health and SUD treatment, that improves access. So next slide. It's the largest source of federal funding for mental health and SUD services. Recent analysis of 2019 claims data showed $58 billion in Medicaid spending on mental health and $17 billion on SUD. So if you think about that relative to other federal programs, it's far and above the highest source. And it does comprise about 50% of funding for mental health, 55% for SUD. Next slide. And just did want to remind, I know that folks on this call are aware of changes in the Budget Reconciliation Act of 2025, sometimes referred to as HR 1 or the One Big Beautiful Bill Act. This almost $1 trillion Reduction, I want to highlight, is an estimate, and it's largely resulting from how the Congressional Budget Office estimates the changes in policy will affect largely enrollment and resulting in, we know, about 10 million people uninsured over the next 10 years, or estimated. And that's primarily due to our over half of that reduction in coverage is due to these new documentation requirements around work, community service, and education for at least 80 hours a month. But there are exceptions for people with substance use disorders, disabling mental illness, and states can request a delay for up to 2 years. So I wanted to highlight just on this slide that states have a lot of discretion in how they implement these new documentation requirements and the exceptions. And it behooves people who are really care about ensuring access to mental health SUD treatment to make sure that states are implementing these changes in a way that really does make sure that people who are eligible remain enrolled. Next slide. There are a couple of other important changes in that act that will greatly impact access, having to do with eligibility redeterminations, cost sharing increases. There is an exception there for mental health and SUD, and restrictions on how states raise funds for the matching rate that they have to, the matching funds that they have to come up with. But again, on eligibility redetermination, et cetera, states, do have some discretion in how they implement that. And unfortunately, the reductions in how they can raise rates is also, or raise matching funds is also going to likely put pressure on coverage, and likely that will fall to optional benefits, which is mostly how mental health and SUD services are covered in Medicaid. So next slide. And that just sort of outlines how those different optional eligibility or authority benefit categories. The Rehab Services Act is widely used to cover things like therapy, crisis stabilization services, peer support, et cetera. CCBHCs are an optional, covered under optional categories, as well as other care coordination and case management services, 1115 demonstrations, home and community-based services. All the key areas that are authorities that are used for covering mental health and SUD are optional, so at risk at this time as states are considering how to address some of the big Medicaid changes. Next slide. But there is an opportunity with this Rural Health Transformation Fund that was included in the same legislation that includes those cuts that will be distributed $50 billion over the next 5 years, half equally among the states, half distributed according to other factors. Eligible providers include some behavioral health providers, but it will be really important as this rolls out, and applications are due in early November, so time is short, but I do think there'll be some ability to influence how that funding is distributed, and it will be really important to make sure that it is going to, for one thing, making sure that people that are eligible for Medicaid or eligible for an SUD or mental health exception are able to access that through technology or other changes that states might consider. So I will turn it back over to you, Laura.
Thanks so much, Kirsten. And can we make sure we get some links in the chat? I see we have a big, long thing of text. This is so important. This is a lot of money. We don't want folks to miss this. Please talk to your state. Anything else you'd leave us with, Kirsten, before I turn it over to Kristen?
Not right now. I know you're short on time.
Awesome. All right. Well, thank you. Let's keep going. And we are going to turn it over for our encore to Kirsten Ellis.
Thank you, Laura. Thanks so much, Dr. Schueller, Dr. Draper, for yet another fascinating and slightly terrifying look at AI mental health apps in 988. Today just reminded me that even as these tools are cool and convenient, the heart of crisis care still stays human. But as usual, we want to thank our sponsor, our headliner sponsor, AHP, for keeping this movement strong. We definitely want to talk to you if you want to help join the sponsor family, because it is what is going to keep things going. Hey, Hal, seems that you stuck around. Do you have any final thoughts on our Crisis Jam today?
I have approximately 19,604 thoughts on the subject. Suffice to say that I have found viable data during this session. Could you please inform me of what I can expect from the Crisis Jam in the following weeks?
Sure thing. That's a lot of thoughts, but we don't have time for them. Next week, keep in mind our Arizona and Hawaii viewers, the time is changing in all the other 48 states on Sunday. So your time will be shifting. We follow Eastern time, 12 noon Eastern. And so your time will be changing when you're going to be viewing us as of next week. But next week, we will be talking with Dr. Madeline Gold, who's going to bring us some insights from the 90-day evaluation report, real data on outcomes and impact. In 2 weeks, we are going to have debate number 9 with Paul Galdas and Joe Parks on how states can best invest crisis capacity, whether they should use their three core crisis services or an alternative view. And in 3 weeks, we are going to have Sophie Schuh be part of our Fireside Chat about youth advocacy and the future of crisis care. Season 6 keeps getting better, even with hell. I guess we'll keep you. Thank you so much for watching. We want to make sure that you tune in, log on, and join the movement every single week, and we will see you next week.